Christine Schneider, the visceral voice.
Welcome to the Visceral Voice Podcast. I'm your host, Christine Schneider. Through this podcast, I aim to bring you the most current, up-to-date research on voice science, function, pain science, movement, and everything in between. I am on a quest to learn everything I can about the living, breathing body and its intricate connection to the voice. This podcast documents the continuation of my learning and my experience as a professional singer, a nutritional consultant, a movement specialist, and a manual therapist. Join us as we strive to provide current, knowledgeable, creative, and compassionate information to help you restore, regain, and create happiness and success on your vocal journey. Hello, everyone. Welcome back to the podcast for our body series. I'm very excited about this series and to kick it off with the amazing Aliza Rudavsky. Dr. Rudavsky is a physical therapist and a professor at Penn State University. She treats performing artists, including dancers and singers, and uses a manual technique for treating the voice called vocal unloading. She is the on-site physical therapist for the students at the Penn State School of Theater, and she also has an appointment in the kinesiology department. Her research is related to the relationship between the pelvic floor and the larynx and how they coordinate to modulate trunk pressures. I had such an awesome time talking with Aliza. We were connected a few years ago. Raymond Sage connected us and we had a great conversation and we really wanted to meet. And then obviously everything happened with the pandemic, and last weekend with our One Body, One Voice, we were actually brought back together and she joined us on a panel, which was really awesome. So I convinced her to please come and be on the podcast for this episode today, talking about the connection and coordination of the larynx and the pelvic floor in her research and what she is finding between voicing and what is happening in the pelvic floor. So really awesome stuff, some new stuff we haven't seen before in research, which is really exciting. And yeah, I hope that you love this episode as much as I do. So here you are, my conversation with Aliza Rudavsky. Do you want to start by just telling us about your journey into becoming a physical therapist?
Sure. So in my previous life, I used to be a modern dancer. And, my mother always said that I needed to have a backup plan, which turns out was a good idea. Who knew? So I got interested in physical therapy, honestly, through my journey as a patient from many injuries as a dancer. And it was something I was always really interested in from a movement standpoint. And I think also as a choreographer and as a dance teacher, I thought that it really resonated with me, the study of movement, rehabilitation, being able to use movement as medicine, I really connected with. So I started going down the journey of PT school sort of while I was also pursuing some, semi-professional dancing. And I took a few years off after undergraduate and danced with some companies in the Seattle area, and then went to PT school and kept dancing a bit and always sort of kept one foot in the performance world while I was, pursuing physical therapy. And then on my physical therapy journey, also started to study more about dance medicine and science. And I did an internship at Harkness Center for Dance Injuries in New York, and started focusing on treating dancers in Seattle. And then after a year of working as a PT in Seattle, my husband and I moved out to Australia. He got a postdoc there and we were living there for about a year and a half. And I worked at a clinic there that was a performing arts clinic. And they focused on mostly musical theater performers. And I was one of the dance specialists there. So in that clinic, I would see musical theater performers and dance students and dancers in our clinic. And then I also they had like I set up an on-site clinic at a dance school there, like a conservatory there. One day a week, I would go and see students just on site. And then we would also go backstage to the musical theater shows and treat the performers backstage as well. And so that was sort of my into some of the vocal stuff that I do. So the woman who ran that clinic there, her name's Annie Strauch, she had learned a lot of these different osteopathic techniques back when she actually worked in London on the West End. And her father was an ENT, is an ENT. So, and she worked closely with speech therapists. So she sort of put together all of these different influences and techniques that she had learned from these different vocal practitioners and developed something that she calls vocal unloading, which she uses to treat musical theater performers, singers, and other occupational voice users, which means basically people who use their voice for work. So teachers, lawyers, any sort of, politicians who are speaking frequently, clergymen, all sorts of people who are occupational voice users. So I learned those techniques at that clinic in Australia, and that was working with predominantly, musical theater singers. And then eventually we ended up moving back to the States, and, a couple of jobs later, a couple of moves later, we've ended up in Penn State in central Pennsylvania. So, and they happen to have one of the strongest musical theater programs in the country. So I am now working here. I have a joint appointment between the kinesiology department and the School of Theater. And in the School of Theater, I am really fortunate. I get to run an on-site clinic for the musical theater students. So I get to utilize all of my dance rehab background, dance medicine background, as well as this vocal unloading. So I do a lot of work with the singers. However, the last year and a half, I haven't because of COVID. But in general, I do a lot of vocal unloading with the singers here. Mm-hmm. And sort of simultaneously tied in to all of this, I had, back in Seattle, started to do some pelvic floor and women's health physical therapy. And that, depending on where I have lived and what my work environment has been a smaller or larger part of my practice. And it's something that's always been on my mind as clearly, directly and indirectly connected to the voice and the vocal mechanism. Mm-hmm. And that there's an enormous influence and contribution from one end of the pressure canister to the other in terms of healthy and normal patterns, as well as abnormal and maladaptive patterns that we see in people with pelvic problems, pelvic health, postpartum, throughout this lifespan in the women's health population, in athletes and in singers and occupational voice users, that there's also some maladaptive strategies kind of between the top and bottom of the pressure canister. So from a research standpoint, that's sort of where I've been starting to drive my research. My PhD was in tendons, and I've made a hard left pivot away from that. So now I'm kind of looking at the trunk and the pressure canister and trying to quantify the relationship between the larynx and the pelvic floor. So that's my journey.
That's awesome. And we're going to talk about that research in just a moment. Super interesting, because I was always wondering how I knew that there was a lot of laryngeal therapy happening in Australia. Yeah. And I knew obviously that it's happening in Europe because I was trained in Europe.
Yeah.
And I didn't realize, so that makes so much sense that Annie got trained in London.
Yeah.
So at the West End, which is where I knew kind of a lot of the laryngeal manipulation and the laryngeal therapy kind of began. Yeah. So cool. So that's how it kind of leapt across the pond
Yeah.
in that direction
Yeah.
and in this direction. Very cool.
Yeah.
I love that you talk about the pressure canister. And I also talk about it as a pressure canister and as a cylinder. So as soon as I heard you when we spoke a few weeks ago, as we were kind of preparing for the panel that we both spoke on for the Penn State conference that Visceral Voice did with Penn State, you had mentioned the pressure canister, and I was like, yes, so much of what you were saying, I was like, oh, Aliza and I really speak the same language. So
Yeah.
it's so cool finding other practitioners when you really, and voice teachers and speech therapists, and when they're speaking the same language as you. So,
well, and actually, the woman who I think probably can claim introducing me to the idea of pressure canister is Mary Massery, who I don't know if she's a physical therapist, and her research really spans the spectrum, but she does a lot of work in the pediatric population and people with cardiopulmonary problems, breathing problems, but also GI. And she talks a lot about the pressure canister, really from also the larynx down to the pelvic floor. But I think, I had come across some research that she and Paul Hodges had done. He's kind of big in the physio world also from like a spinal stability standpoint. And they were kind of the first people to describe that the larynx even has a role in standing balance, that it's important in standing balance, and the position of the larynx and the function of the larynx is modulating pressure in a way that's actually helping to regulate and facilitate inner core coordination and balance. Just like for people who are standing on a force plate and getting nudged to the front or to the back, when they're speaking or vibrating their vocal folds, they have better balance than when their glottis is either completely closed or completely open. So they were kind of the first people to start describing that. And I was like, I wonder if that's different in people that have had recent changes to their pelvic floors. I wonder, in a postpartum population where they've just had a massive stretch, possible tear, possible trauma to their pelvic floors, if they need to use the glottis in a different way, or if they can rely on a glottal strategy because they are lacking sufficient pelvic floor strategy. So that was a digression, but yeah.
No, that's awesome. And Mary and Paul, where are they? Are they here in the
Paul's
States?
Australia. He's in Australia. He's at the University of Queensland in Australia. He's absolutely brilliant. His work also spans a lot of different areas. He does a lot of pain research, a lot of core, pelvic floor. He's now doing a lot of like male pelvic floor research, but also he's done some research on singers and breathing, and he's absolutely brilliant. And Mary is in Chicago now, and we've collaborated a bit on some research. So she's brilliant. And if anybody, she has a course called "If You Can't Breathe, You Can't Move," and it's brilliant. She's wonderful.
That research kind of led you into your research that you've been doing.
Yeah. So
involving the pressure canister, looking at the larynx and the pelvic floor. So tell us about your current research.
So currently I'm trying to identify what's happening in the pelvic floor when we're voicing. And I'm looking at it through a couple of different modalities. Currently, I'm using ultrasound, real-time ultrasound, just two-dimensional. And we're trying to quantify how the pelvic floor is moving. And so if you think of the pelvic floor as a sling or a bowl, kind of in the opposite direction. I realize I'm making hand motions and this is a podcast. If you can picture in your mind how the diaphragm is sitting, and you think about the abdominal cavity being an oval and the pelvic floor is sort of the bottom dome. And so it's in the opposite orientation of the diaphragm, the respiratory diaphragm. But the pelvic floor and the diaphragm coordinate during natural breathing, where they both descend on inhale and elevate on exhale. There's a lot of incorporation of breath and more different voicing tasks into pelvic floor physical therapy. And I was curious sort of what the science behind some of that was. There's some practitioners who are describing that when you speak in a really low pitch, that the pelvic floor descends, and when you speak in a really high pitch, that the pelvic floor elevates. And so I wanted to measure that and see if that's accurate, because I think that while that might be what they are feeling on digital palpation, which is just literally when you have your hands on the perineum or inside the vagina, that you may be feeling something similar to that. And, we're looking at that on ultrasound, and we're not really seeing a change in pelvic floor displacement that's consistent with changes in pitch, but we are seeing that as volume or intensity of speaking voice transitioning from speaking to yelling voice, as that volume increases, we're actually seeing more of a pelvic floor descent. And we see that in a healthy population, and we're just starting to look at a population of women with pelvic floor dysfunction. So I don't have enough data to really describe what we're seeing, but it's so far the people that have had pelvic floor dysfunction that we've looked at, it's definitely different, the different coordination. And I think what we're going to end up seeing, just based on what previous literature has shown, is that people with pelvic floor problems, when they have those sort of quick, high intensity forced exhalation, like a cough, they either grip with everything they've got in the pelvic floor, which would be sort of that lifting up of the pelvic floor and tightening, or they don't, and they leak and they have problems. And I think that those with pelvic floor problems are not able to get that nice controlled lengthening of the pelvic floor that we're starting to see on ultrasound in the healthy population. That as that pressure demand from the top of the canister increases, there's got to also be some sort of controlled adaptation or accommodation of that increased load on the pelvic floor. And in the absence of that controlled lengthening of the pelvic floor, there's either going to be a gripping strategy or a failure strategy, which is leakage or prolapse or something else along those lines. So that's what we're looking at now. We also, in the future, once we get our funding, are going to be looking at actually measuring intra-abdominal pressure while doing a whole battery of vocal tasks. So measuring different acoustic parameters. Also, we would like to be doing measuring EMG as well. So measuring the pelvic floor muscle activity. And we want to really get a sense of what's happening in a normal population. So we kind of know what we should be striving for and what is normal and what's not normal, because I think if you would tell many pelvic floor therapists that actually it is normal to be able to lengthen a healthy pelvic floor when somebody is yelling, they'd be like, really? I had no idea, because it's just like not described yet in the literature. And then we want to get a sense of what is happening in people with not just with pelvic floor problems, but also with voicing problems. Like, do people with muscle tension dysphonia, are they also unable to sufficiently lengthen their pelvic floor, that they can't kind of preload their intra-abdominal pressure system in order to pressurize their voicing? So then they're gripping in their secondary or auxiliary respiratory muscles that are, surrounding the larynx, like SCM and scalenes and all these other sort of perilaryngeal muscles. And then their larynx can't tilt optimally. So then their vocal folds are slapping together, and then they're developing nodules and yada, yada, yada. So, how relevant is pelvic floor flexibility and motor control and strength and coordination for the singing population and the speaking population? And, is that potentially setting our pelvic floor problems potentially a risk factor for developing voice problems? Like
and vice versa, potentially.
And vice versa, of course, and vice versa. I think it all goes both ways. I think it's bidirectional, absolutely. Meaning that, the vocal coordination, control, flexibility, strength, coordination of all of the perilaryngeal muscles are influencing the function of the diaphragm and therefore the pelvic floor, and vice versa. Absolutely.
And so in the research that you did with some yelling and with some coughing, now were you seeing that the pelvic floor, as it was coming into that eccentric contraction or that descension, that lengthening, was it coming into that and staying there, or was it buoyant? Was it coming in and
Definitely
coming
buoyant. So
back?
interesting.
Yeah.
So at this point, I can't say definitively if it's an eccentric contraction because we don't have EMGs in there.
Mhm.
So an EMG is measuring the muscle activity. And if you're not, in order to measure an eccentric contraction, which is a muscle contraction while the muscle is lengthening, you need to be able to both measure muscle length change and muscle activity, like electric activity. And we're not doing the EMG right now, so we're just getting the change in length. However, what's so interesting is right now the vocal task that we're looking at is counting to 4, and it's on one exhale. So it's just 1, 2, 3, 4, all on one continuous exhale, which you would think if you're following that that sort of piston coordination between the diaphragm and the pelvic floor, that your lungs are exhaling while you're phonating. So the whole time that you're counting to 4, you're exhaling. So the diaphragm is elevating. So you would think that the pelvic floor would also be elevating that whole time. However, we actually see this responsive lengthening to each word that they're saying, totally independent of the breath pattern. So the pelvic floor, it seems to be on the videos that we're taking responsive to voicing more so than to breath during phonation,
Mm.
which is
Which is
fascinating.
different than what we've seen before, right? With actual natural breathing, because with
Correct.
natural breathing, we saw
Coordinating
them,
breath.
this coordination with the
Absolutely.
respiratory diaphragm and the pelvic floor. And now you're actually
So
seeing,
as you're starting to increase the subglottal pressure demand in order to speak, because you don't have to generate subglottal pressure for natural breathing, but you do have to generate more pressure to phonate. And that, as we're starting to dial up that pressure system at the top of the canister, we're seeing this responsive reaction in the pelvic floor to the immediate real-time vocal demands or subglottal pressure demands. We're seeing it in the pelvic floor. And it's so interesting, on one exhale where they're counting 1, 2, 3, 4, only when they're speaking the words, you see this up, down, up, down, up, down, up, down. It's really interesting. So yeah, and it's that lengthening of the pelvic floor on the voicing task. So yeah.
Yeah. Okay. And so
Wild.
now that's all been with healthy pelvic floor
Yep.
and healthy phonation. So now you're starting to venture into working with people who may have pelvic floor dysfunction.
Correct.
And then you're also going to add on those who might have some vocal dysfunction.
For the ultrasound study, it's just going to be women with and without pelvic floor dysfunction. However, for the intra-abdominal pressure and subglottal pressure, the future study that we haven't done yet, it's going to be all women with and without pelvic floor disorders and with and without vocal disorders.
Okay, cool. So you just mentioned the intra-abdominal pressure. So I do want to start chatting a bit about this pressure system to the listeners. We did have an episode with Gail Wetzler from the Barral Institute back in, I think, season 2, if you look at the breathing series that we had. And Gail talks about voluntary and involuntary control of the breathing and the gas exchange. And then she talks about the pressure system in regards to the atmospheric pressure, the alveolar pressure, and the intrapleural pressure. So all the things that are happening up around the lungs and within the atmosphere. But there's also intra-abdominal pressure.
Mm-hmm.
So, Aliza, talk to us about this component of the pressure canister.
I would say there's some controversy around intra-abdominal pressure in that I think that there's this idea that intra-abdominal pressure is bad. And I can understand where that comes from because I think a lot of problems in the abdominal cavity can be exacerbated by either elevated intra-abdominal pressure or I guess lack of control of or modulation of intra-abdominal pressure. So like pelvic organ prolapse that's when your pelvic organs just kind of drop down. It's not uncommon, particularly after pregnancy, when everything has been stretched and, the stiffness in all of your ligaments has temporarily diminished. And if there's been any trauma in your abdominal cavity, that can also contribute to just laxity. And then you go through and you add in a bunch of intra-abdominal pressure and everything kind of just drops down or slams down, and you can have pain, or you can have leakage, or you can literally have like organs falling out. Like some women have to literally splint their organs up when they go to empty their bowels and bladder. And however, intra-abdominal pressure is really important for a lot of reasons. It stiffens and stabilizes your spine. It allows you to lift things up. It allows you to cough and speak and clear your throat, and to empty your bowels, and to do a whole bunch of things. So it's really important to be able to generate intra-abdominal pressure. It's really important for standing balance also, and for something like that where it's a reactive activity, you have to be able to generate it really fast. I think that what's important with intra-abdominal pressure is that you can generate it quickly, and you can also modulate it. So it needs to be able to be something that's not always a chronically elevated intra-abdominal pressure to the point where, you're basically like loading your entire abdominal cavity all the time. It's like as if you had a brick in your tummy all the time. Like, you don't want that. That can also cause GI problems and other respiratory problems. And I think a lot about this. There's a particular body type of like middle-aged or older men that have kind of that like barrel chest and that big gut that's sticking out. That's like, it's not necessarily fat. Like, I actually think it tends to be pressure, chronic overloaded intra-abdominal pressure that they can't really move their rib cage at all. Like, kind of comes with a stiff rib cage and a poor breathing pattern and inability to draw the abdominals inward. And yeah, so that can be like a type of problem that happens when you have this sort of chronically overloaded system. But if you have a chronically underloaded system where you can't say like the wall to the abdominal cavity has no tone or tension to it, which again, when does that happen? Right after having babies. You have no tone in your abdominal wall, and you can't generate intra-abdominal pressure, and certainly not quickly. Then you run into problems when you have to go to the bathroom or sometimes speaking or coughing, that it's actually like hard to clear your throat because you can't generate that intra-abdominal pressure. You can't stiffen up the walls of your abdominal cavity quickly enough to generate pressure. So then it's a low pressure, it might be a bigger volume, but a low pressure system or cavity at that stage. So that's also not really ideal. So I don't think that we should be putting like a low pressure abdominal cavity sort of on a pedestal, because you need to be able to generate pressure.
I just wanted to take a moment to tell you about some exciting things happening at the Visceral Voice. The first one I wanted to tell you about is the Visceral Voice Musical Anatomy apparel. These are super fun images that we have created here at the Visceral Voice onto shirts, and these are available at the Visceral Voice on eBay. And of course, you can always contact us and let us know your size, and we can pre-order for you as well. So that is the Visceral Voice Musical Anatomy. We have one image up right now. We have another one coming out in a few weeks, and we have 4 or 5 that are also coming out this year. So please take some time and check that out. The next thing I wanted to tell you about is our Pelvic Cathedral class. If you want to learn more about the connections of the larynx to the pelvis, learn more about pelvic anatomy, and learn more about your body systems, your subsystems, please join me for the Pelvic Cathedral beginning Tuesday, October 12th at 6 p.m. Eastern Standard Time. This is a 9-week class, and we go over all things having to do with the Pelvic Cathedral. The last thing I wanted to take a moment to tell you about is our next 8-week self-care class, The Body of Singing. This begins Sunday, October 3rd at 6 p.m. Eastern Standard Time. And we go over a lot of our self-care for the singer. All right, everyone, we are super excited about these upcoming classes. If you have any questions, please contact us at thevisceralvoice@gmail.com, or to register, head on over to www.thevisceralvoice.com. Now back to the show.
So I don't know if that answered your question, but
Yeah, needing to be able to generate pressure, but not over generating pressure, not bracing.
It's all about modulation. You have to be able to modulate in the thoracic cavity, in the abdominal cavity. You have to be able to modulate. So be able to I think that our whole body systems function better on a dimmer switch versus a light switch. So it should not be an on-off. You should be able to modulate between dimness. And that's for everything. That's that's my movement philosophy, is dimmer switch.
Mm-hmm. And then these pressure systems, so the intrapulmonary, intrapleural, and intra-abdominal are all they're all a unit in a sense.
Yeah, I mean, it's basically the trunk is for all intents and purposes, it's one continuous canister, and what divides it in the middle is the respiratory diaphragm, which is, it's the main driver of the thoracic pressures, the lung pressures, and it's also the main driver of the abdominal pressures. I mean, I think also the transversus abdominis and other abdominal muscles are heavily involved in regulating intra-abdominal pressure, but it really all works together. And I think in general, the diaphragm is the primarily responsible muscle for both, for both systems. So you can't have change in one system, which is caused by the diaphragm, that's not affecting change in the other system.
Yeah, right. I always think of these as the thoracic cavity, like the accordion, changing volume and shape, and the abdominal cavity changing shape and can change volume if we're eating. But as far as breath is concerned, one is like the accordion and one is like the balloon. So we're not changing the volume per se within, our breath air is not going down into the abdominal cavity. That's happening through the movement, and through that movement has that pressure.
Right. So as the diaphragm is coming down, then it's pushing down on the abdominal contents, which is going to displace them as well. And there's a lot of organs in the abdominal cavity, and they're mobile. So they're just,
we hope.
Yeah. When they're not, that's a problem. But it's interesting because all of the organs are also responsive to changes in intrathoracic pressure, because that's affected by diaphragm movement, and the diaphragm needs to be able to move up and down. And well, what's it moving down on? Your organs, your abdominal organs, your abdominal contents. So yes, while it's not directly air coming down into the abdominal cavity, it is a distortion of the shape of the cavity, which is going to, if you think about the diaphragm coming down on an inhale and pushing down on the abdominal contents, if you have too much stiffness in your pelvic floor or in your abdominal wall, which a lot of people have a lot of stiffness in their abdominal wall from sucking in all the time, where is that where is that pressure going to go? So if your abs are too stiff and they don't allow for that expansion or that attenuation of those forces from the diaphragm coming down, it's going to come out the bottom, which is your pelvic floor. Or vice versa, if you don't have sufficient lengthening of the pelvic floor as the diaphragm is coming down, the diaphragm might not be able to come down enough, and you might not be able to get a breath, or you might not be able to get a big enough breath or an efficient enough breath. That stiffness or lack of pliability in certain places in the abdominal cavity might limit that transition of forces or pressure from between the two cavities. Again, they have to be responsive to each other. And it's sort of, I think of it almost like a ping pong ball, that it keeps on going up and down and up and down and up and down, because you don't want like a high pressure environment in both cavities at the same time. It's sort of the opposite. You're moving up and moving down and back and forth. So, but displacement and length and shortening of the walls of the cavities to kind of adapt to those changes.
You mentioned modulation of the pressure system. Do you have examples or strategies on ways to help coordinate that?
Voicing.
Yay!
So it's, it's really hard to measure and cue people to modulate their intra-abdominal pressure. And honestly, that's a main driver of the work that I'm trying to do, by tying in the vocal system, because I think that it's just easier to, and again, we haven't actually measured intra-abdominal pressure yet during voicing, so I can't say for certain that we are modulating the pressures, but you can sort of infer because you're modulating subglottal pressures and thoracic pressures, so therefore abdominal pressures, all things being equal, which they're not, obviously, but if they are, you are. And honestly, it's kind of like the same as cueing an eccentric contraction of the pelvic floor. It's like, how the heck are you going to cue somebody to do a controlled lengthen of their pelvic floor so they don't sneeze so they don't pee when they sneeze? And typically what the cue is, and this is like sort of the classic pelvic floor therapist education piece, is it's called the knack, and it's squeeze when you sneeze, or squeeze before you sneeze. Or now they're sort of transitioning to blow before you, I think it's blow before you go. When you're about to lift a heavy task, blow out before you go. So I think, that those are cues that are being used to modulate pressure in the pelvic floor. And blow before you go is to exhale before a heavy lifting task, or a moderate lifting task. So you don't have too much pressure in your abdominal cavity that you would either blow out a disc or something in the abdomen, like either prolapse or leakage. But yeah, I think that voicing is nice because there's so many different ways that you can modulate it. You can have somebody counting, you can measure volume, you can have somebody like counting in a speaking voice, counting in a loud speaking voice, counting in a yelling voice, kind of as like a progressive loading system that is modulating pressure, and you're controlling it. I guess the difference for me between like blowing out versus speaking is that there's a little bit more resistance. There's resistance of the vocal folds vibrating, or the pressure having to overcome the resistance of adducted vocal folds. So that gives you a little bit more to work with. It's kind of, so I also sometimes will use a straw. So thinking of like the semi-occluded vocal tract types of exercises, that's another extension of resistance to the exhale, which also is another way to just create a little bit more of that control of that modulation, of that release of pressure. Mm-hmm. So those are kind of, I think that I'm going to be incorporating a lot more counting and speaking into, pelvic floor loading programs. And I'd like to play more with the straw. Honestly, I think that breathing in and out of a straw and speaking or singing into the straw is really interesting to me as another way of both like potentially creating some suction in the abdominal cavity and some of that controlled like eccentric or abdominal pressure overload. But unfortunately right now I had to take it out of my study because of COVID.
Oh, right. Yeah, I think as we're talking about the top and the bottom of a canister, you were talking about taking some of what we have learned with Ingo Tietz's work and in the SLP world, and bringing those semi-occluded vocal tract exercises into potentially retraining the pelvic floor or working with pelvic floor dysfunctions.
Yeah.
And then on the flip side, you and I have chatted because I've been using the Pelvic Pro,
right,
not knowing that the singers that I've been working with have any kind of pelvic dysfunction because it's not common to talk about those. People
Right.
don't talk about incontinence very often, unless asked.
Right.
They don't talk about incontinence. They don't talk about painful intercourse. They don't talk about prolapse.
I would just add to that. It's not only that people don't talk about it unless asked, it's that people don't often realize that what they are experiencing is not normal. So I think it's both, because sometimes
Totally.
even if you ask, they're like, no, it's totally fine. And then you go into a little bit more pushing, and it's like, oh, you know what? I do actually have pain when I'm putting a tampon in sometimes. Or, it's like, I do sometimes leak when I jump on a trampoline. Huh, is that not normal?
Yes.
Anyway,
Yes.
sorry.
Totally.
To digress
No,
on
it's
that.
super important to mention that. And yeah, so I didn't even know that, but I thought, okay, I was getting trained in the pelvic chain reaction. And I thought, I'm going to start using this with singers and just see what happens. And as it's been really assisting their vocal production, it's really helping with things that I didn't even know about. And maybe, like you just said, maybe they didn't even know about. And then they'll say, gosh, Christine, this is helping me here. And it's really, really cool to see how working with one side can affect the other side and vice versa. So my question, and this is opinion and not research yet, because you're going there with your research, but do you think that it is likely that many people with vocal production limitations may have pelvic floor dysfunctions? Do you think that it's possible that a lot of times those go hand in hand?
Yes, I do. I think that so much of vocal, or so many different vocal problems, particularly in the sort of overuse domain, are related to breathing problems. And I just think once there's like a breathing problem in there, there's a pelvic floor problem in there, probably. Not always, but I think that I certainly think it's much more prevalent and should be much more on our radar than it currently is. And I think it would be very unlikely that you would find your everyday SLP asking about pelvic floor problems in their clinic. And I hope that in the future, in a typical speech therapy evaluation, there do start to be standardized questions about pelvic floor function, and vice versa. I hope that in a pelvic floor therapy initial evaluation, your PT is asking about what your vocal load is, and any vocal symptoms, because I do think that they are likely to go hand in hand. I don't think it's going to always be the case for every single person. I don't think every voice patient is going to have a pelvic floor evaluation, but I think it's something that we need to be much more aware of. That's my hope.
Mine as well. And as I've spent the last year really diving into the study of the pelvis, this is the perfect episode to open this series with, and having you as part of the conference was just so incredible as I've started working with the pelvic floor more and more, and working all around the pelvis more and more, and really noticing what you have been noticing as well, as this amazing connection. And we know these anatomical connections that it has, and embryology, et cetera. But to really see it in the clinic, and to really see how it is coming into someone's life, it's really profound. And so to really link these two together, I think exactly like what you just said. I agree with you 100%. Bringing it into our radar a little bit more, bringing it into our discussions and our evaluations.
Yeah, and I think so. One of my mentor for pelvic health is a woman named Kathy Wallace, who really sort of pioneered pelvic floor physical therapy. And she always says that, the clinical practice is always light years ahead of research and science, and you need to just start, going with being creative in the clinic and moving forward with what you're seeing in the clinic. And I think it's not a coincidence that radicals like us are starting to make these connections. And I've talked to a number of different practitioners in different domains between the larynx and the pelvic floor that are starting to kind of put these pieces together that are clinically oriented. And I think that, again, it's not a coincidence. We're all kind of starting to bring our awareness to these connections and see how influential the top and the bottom of the canister are on each other. And hopefully in the next couple of years, the science will catch up. And we can have, we can understand why a little bit better. But I think that, you're intuitive about it. And I think that you're making the connections that are really important to be made in your clinic and spreading the gospel. So.
Oh, well, you too. So I deeply respect and appreciate all of the work that you're doing and all of the research that you're doing to allow us to really know you're proving what we are finding clinically, which is really awesome. So really, from the bottom of my heart, thank you for all the work that you do, Aliza, for being on the podcast today and coming and talking with us about the canister and about your research. And it has just been awesome talking with you.
Thank you so much. It's been such a pleasure. And I also have so much respect for the work that you're doing in the podcast and getting the education out there. So thank you so much.
Thank you all for listening. If you enjoyed this podcast, tell your colleagues, students, and friends. Subscribe, rate, and please write a review. You can find us on Instagram or Facebook, and feel free to check out my website at www.thevisceralvoice.com for information on programs and upcoming events. I hope you join us next time for another wonderful conversation on the Visceral Voice.